in the roof of the oval fossa. Now we can see rather nicely here the point where the inferior cable vein opens in posteriorly to the right atrium, and there you are seeing the orifice of the inferior cable vein. We can see very nicely here the remnant of the eustachian valve, the valve of the inferior cable vein, and you know that that structure enters the septum between the oval fossa and the coronary sinus septum, where it joins with this valve of the coronary sinus, the Bézian valve. The two fuse together, form the tendon of Todaro, which Dr. Ho demonstrated to you in one of our previous demonstrations, and that runs through the sinus septum towards the central fibrous body. So the larger part of the atrial septum is this floor of the oval fossa, its inferior rim, the sinus septum. But it's also important that you appreciate that opening into that sinus septum is the coronary sinus. And the coronary sinus runs, as you know, along the left atrioventricular groove. You see, I'm passing my probe along the atrioventricular groove, and eventually it emerges through the lateral margin of the coronary sinus, so that we can see how the coronary sinus occupies the left atrioventricular groove. Now, an understanding of this is going to be very important when, at the end of this demonstration, we discuss coronary sinus defects found at the mouth of the coronary sinus here, because you can clearly see that this wall of the coronary sinus is a party wall between the extension of the right atrium, the coronary sinus, and the left atrium, which I demonstrate by passing my probe through this party wall. So if there is a hole in this party wall, that would permit the mouth of the coronary sinus to function as an interatrial communication. I now want you to focus your attention on this superior rim of the oval fossa. The floor of the oval fossa is this flap valve, and we're going to look at that very shortly in a different heart. But what this section emphasizes most beautifully is that the superior rim of the oval fossa is an infolding of the atrial wall between the superior cable vein, which I'm holding in my right hand, and the right pulmonary veins, which enter the left atrium in this location. So that, although I could pass my probe from the cavity of the superior cable vein across this groove and into the left atrium, it would not be passing through atrial septal tissue, because it would have to pass outside the heart before it was able to reach the cavity of the left atrium. The point I am making is that this infolded superior margin of the oval fossa, although very frequently described as the so-called septum secundum, is not a septal structure at all. It is the infolded walls of the atrial chambers. Here, the wall of the left atrium, and here, the wall of the right atrium. So now I'm going to show you the relationship of this infolding on an intact septum, because this fold is crucially important. It is the interatrial groove, Waterston's groove, or as it's called on the continent, Sondergaard's groove. And it's very important to appreciate the relationship between Waterston's groove and the terminal groove marked by the position of the terminal crest. And that permits us to understand the relationships of the oval fossa to the mouth of the superior cable vein and the mouth of the inferior cable vein. So now we've moved to a more intact, normal heart, so that we can look at the relationships of the cable veins to the septal structures. You will recognize the typical right atrial appendage, the blunt triangle. You will recognize the terminal groove marking the junction between the appendage and the venous component of the right atrium. Now first I'm going to open up the atrium so that we can look at the internal morphology, and then we'll come back and we'll look at the external arrangement of the venous sinus of the right atrium. When we open up internally, we immediately see terminal crest marking the border between the smooth-walled venous sinus of the right atrium and the trabeculated appendage. We see that in this particular heart there is a prominent valve of the inferior cable vein. And looking down there, we see the wide open mouth of the coronary sinus. Mouth of the inferior cable vein. Here, of course, is the coronary sinus beneath the valve of the inferior cable vein, and we see the coronary sinus guarded by its own trapezium valve, and we know that those two valves join together to form the tendon of Todaro, marking the superior border of the triangle of Koch. Now, the focus for today's presentation is this area of the atrial septum. As an aside at this point, something we're going to emphasize with the hearts we look at with septal defects, it is crucial to differentiate between the venous valve of the inferior cable vein and the oval fossa, because it would be very easy in some instances to go into the right atrium and to imagine that this was the boundaries of the oval fossa. If a patch were placed across there, of course, it would wall the inferior cable vein into the oval fossa and into the left atrium. So we must distinguish between the margins of the oval fossa, deep to the valve, and the valvar structure guarding the mouth of the inferior cable vein. So the oval fossa is on the septal surface of the right atrium. And by putting that pressure on, I have very nicely shown you the rim of the oval fossa and the flap valve in its floor. Now this rim of the oval fossa is the part that previously has often been called the septum secundum. And the anterior margin has often been considered to be part of the atrial septum, as has this mound here above the insertion of the tendon of Todaro. All of these areas are simply infoldings of the atrial wall and are not septal structures. This mound in this position, as we can see by folding back the atrial wall, sits in relationship to the non-coronary sinus of the aorta. So it is crucial that those who try to do septal punctures do not puncture in this position, since if they do, their catheter will pass into transverse sinus and into the aorta. So we must recognize that the anterior margin of the atrial septum is the rim of the oval fossa, and that this is the anterior interatrial groove. It is this superior rim that I showed you just a few moments ago in our four-chamber section. And now we can see that this is the medial margin of the venous sinus. And now if we fold back the wall of the atrium, we can beautifully see how, looking at the venous sinus from the back, we have the superior cable vein, the mouth of the inferior cable vein. We have the venous sinus bordered laterally by the terminal groove, and medially we see the border of the venous sinus is this deep groove between the opening of the superior cable vein, the opening of the right pulmonary veins. And this deep groove is occupied by fat. I have dissected it in this heart so that you can see the depth of the infolding of the atrial walls that produce it. The English and Scots anatomists call this Waterston's groove, after David Waterston. The continental surgeons call this Sondergaard's groove, after the famous Swedish surgeon Sondergaard. Probably it is better simply to call it the interatrial groove. The point we must remember in relationship to atrial septal defects is that it is the groove that forms the superior margin of the oval fossa. So that in reality, the extent of the atrial septum, as we can see moving over and looking into the left atrium, the true atrial septum is the flap valve. It is a very thin structure. In 1/3 of all normal hearts, as in this adult heart we are looking at the moment, the flap valve is not fused to the underlying rim, so there is what we call a probe patent oval foramen. The probe patent oval foramen, of course, will be of no functional significance as long as the pressure within the left atrium is higher than the pressure in the right atrium, because then the margin of the valve, sufficiently great to overlap the rim of the fossa, will be firmly closed against that muscular rim, so that no shunting is possible across the defect. But if there is any circumstance in which right atrial pressure should rise and exceed that in the left atrium, then at that stage this probe patent foramen ovale would be of functional significance. And we see sometimes that in deep sea divers, so it is a problem for deep sea divers to have a probe patent oval foramen. We also see that in extreme pulmonary hypertension, when the pressure on the right side of the heart can raise to the extent that it exceeds that in the left atrium. So those are the circumstances in which the probe patent oval foramen becomes of functional significance. But today we are primarily concerned with congenital deficiencies here in the oval fossa. Now, before we move on to those deficiencies, I want to show you one more heart to emphasize the relationship of the coronary sinus to the left atrioventricular junction and to the atrial septum. Now, the view I'm showing you at the moment, which again is a normal heart, is a particularly important section. It's a section we're going to look at again and again in the talks that are going to follow. So let me take a little while and orientate you as to how we have produced this dissection. You are looking at the base of the heart from its atrial aspect. This is the right atrioventricular junction. This is the left atrioventricular junction. Here you see the typical left atrial appendage, which you should recognize by now. And you see the narrow junction between the left atrial appendage and the left atrium, and you see the smooth posterior aspect of the left atrioventricular junction. you see the pulmonary trunk with its valval leaflets completely supported on the freestanding subpulmonary infundibulum. And that is something we are going to emphasize in our future presentations. You see beautifully the aorta occupying the center of the short axis of the cardiac mass. You see the left coronary artery, the right coronary artery, and you see the non-coronary sinus of the aorta with its non-coronary leaflet interposed and wedged between the front of the tricuspid valve and the mitral valve. And you note how this wedge position of the aorta lifts away this leaflet of the mitral valve, which we call the aortic leaflet, lifts it away from the septum. Now, the topic for today's discussion, of course, is the atrial septum and its deficiencies. And you will appreciate that having made this dissection, there is very little left of the atrial septum. In fact, this shows you very beautifully this infolded anterior atrial groove, and shows you how the wall anteriorly of the right atrium is directly related to this non-coronary sinus of the aorta. You can see that there is a very short margin here, which is the inferior rim of the oval fossa, and that is directly continuous inferiorly with this area, which is the atrioventricular muscular septum, because the leaflet of the mitral valve is attached more towards the base of the heart than is the leaflet of the tricuspid valve. But what I want you really to concentrate on in this dissection is the relationship between the coronary sinus, the right atrium, and the left atrioventricular groove. Here you see the party wall between the coronary sinus and the left atrium. The coronary sinus, of course, derived from the left horn of the embryonic venous sinus, functions in the normal heart as the conduit for venous return from the heart itself. So you see here the mouth of the middle cardiac vein, which comes up the posterior interventricular groove with the posterior artery, the small cardiac vein draining with the right coronary artery opens laterally in relationship to the coronary sinus, and the coronary sinus itself starts beneath the mouth of the left atrial appendage at the point where the great cardiac vein turns around the obtuse margin and enters the left atrioventricular groove. And if we look carefully down here, at this point we see that the wall of the coronary sinus is separate from the margin of the left atrium, but from this point onwards there is a party wall, so that any deficiency here would permit left atrial blood to enter the coronary sinus and to flow into the right atrium through its mouth. And as we will see, very frequently that is a congenital malformation which turns the mouth of the coronary sinus into an interatrial deficiency. So, now you understand the anatomy of the atrial septum, we are in a position to understand the anatomy of interatrial communications. And this large heart, with a rather interesting lesion within it, serves to show us the essence of the commonest form of interatrial communication. So as we obtain our landmarks, we see here the right atrial appendage, typical pectinate muscles, superior caval vein, and the inferior caval vein. Opening the right appendage shows us beautifully the pectinate muscles surrounding the right atrioventricular junction, and interestingly, we see that the leaflets of a hypoplastic tricuspid valve are fused and blocking the right atrioventricular junction. Last week I showed you an imperforate tricuspid valve in the setting of Ebstein's malformation. Here we see an imperforate tricuspid valve that is also hypoplastic. This is a very rare lesion. We see that the leaflets clearly initially had been patent. Now they have fused together. So what initially was a concordant atrioventricular connection on the right side has been turned into an imperforate tricuspid valve, giving us tricuspid atresia. I should emphasize again, as I did last week, that this is the rarer form of tricuspid atresia. In the typical classical example of tricuspid atresia, there is complete absence of the right atrioventricular connection. But clearly, if the leaflets of the tricuspid valve have fused, there must be some other way for the venous return coming back to the right atrium to reach the left side of the heart. And to find that communication, we look at the oval fossa. And here is a very nice example of a deficiency within the oval fossa. Now, if we look at the boundaries of the oval fossa, we see that here is the superior rim. We see that here, lateral to that, is the opening of the superior cable vein. Superior cable vein bounded laterally by the terminal groove and the terminal crest, medially by the superior rim of the oval fossa. We know that this superior rim is the infolded atrial wall, and we know that that is contiguous here with the aortic mound. Here we see some remnants of the valve of the inferior cable vein. These are so-called Chiari remnants, and you see that they are in fact reinforcing the floor of the cable vein in this position. Here is the remnant of the eustachian valve, and we see another little remnant of the Thebesian valve in the mouth of the coronary sinus. And here is the sinus septum with the eustachian valve entering that as the tendon of Todaro, and there beautifully you see the tendon of Todaro running down to mark the superior margin of the triangle of Koch. There is beautifully demonstrated the triangle of Koch, the tendon of Todaro, the attachment of the leaflet of the tricuspid valve, and forming the base of the triangle, the coronary sinus. But the focus of our attention should be the oval fossa. And in this heart, the flap valve of the oval fossa is of insufficient dimensions to block off its margins. Here is the superior rim, and the black hole you see is the superior deficiency within the oval fossa. Not only that, the lower margin of the flap valve is cribriform. There are several holes here, so that there are communications within the body of the flap valve of the oval fossa. And we will see those better if we turn this large heart over and we approach it from the left side, because now very beautifully you can see the extent of the flap valve, and you see that the flap valve is insufficient to overlap the margin of the oval fossa. In addition to that, you see the cribriform lower edge, with this part being a little patulous and aneurysmal, and oftentimes the entire valve can be aneurysmal to the left side, particularly in the presence of tricuspid atresia. It can be aneurysmal to the right side when there are obstructive lesions in the left heart, and we will look at that in the setting of mitral atresia. But here we see the cribriform lower nature of the lower end of the flap valve of the oval fossa. So here, beautifully, in one heart, we see the two mechanisms which produce defects within the oval fossa. On the one hand, the upper margin of the flap valve is of insufficient dimensions to overlap the rim. On the other hand, the lower margin of the flap valve is cribriform, so that blood can pass directly across the floor of the oval fossa. And you will appreciate that the dimensions of the deficiency within the oval fossa will depend upon the extent to which the flap valve is preserved as a valvar mechanism. The more deficient this upper edge, the larger the hole, the greater the cribriform, or the punched out nature of the flap valve itself, the greater the potential for communications across the fossa. But if we return to the right atrium, what I want to emphasize is that these are the only true atrial septal defects. Because you see that the margins of the atrial septum, by and large, are delimited by the rims of the oval fossa. Beneath the oval fossa, we have the atrioventricular septum. Superior to the oval fossa, we have the mouth of the superior caval vein. Behind the oval fossa, we have the mouth of the inferior caval vein, and postero-inferiorly, we have the coronary sinus separated by the sinus septum. So it is only holes within the oval fossa that are true atrial septal defects. And you can imagine that the largest true atrial septal defect is going to be found when there is complete absence of this floor of the oval fossa. So I'll now show you such a heart with complete absence of the floor of the oval fossa. Now you're looking at a much smaller heart in this instance, and one in which the tricuspid valve is patent, but we can very beautifully now see the relationships to the oval fossa, and we can see that the oval fossa is virtually entirely unguarded. So here is the opening of the superior caval vein, the inferior caval vein in this location. Again, we can see the site of the tendon of Todaro coming forward, marking out the triangle of Koch. But now, beautifully, we see that the entire floor of the oval fossa is missing. There is a simple remnant here posterior of the flap valve, but this is as large a hole as you can have through the oval fossa. We see that the rim is a little bit stretched, and certainly it is the case that with pro-patent oval foramen, if the heart itself is distended, it's easy to imagine how the rim of the oval fossa can be stretched to permit production of an intra-atrial communication, which then, when the heart becomes less distended, blocks off. And that, to me, is the common mechanism whereby we get so-called spontaneous closure of atrial septal defects. It's very difficult to imagine how in a hole of this size, or even one where the flap valve blocks half the dimensions of the oval fossa, it's difficult to imagine how such a defect could become spontaneously closed. So if we look into the left atrium in this heart, again from the left side, we see very beautifully that there is the merest remnant of the flap valve of the oval fossa, a large defect between the superior rim, which of course is the infolded atrial wall, as we have established, and the lower limb, which is the remnant of the flap valve. Now, before we move on to more complex defects, I want to emphasize the relationship of the inferior caval vein to the posterior margin of the oval fossa. Here we're looking at this small heart from behind. So here is the crux, Here is the posterior interventricular artery, and this is the opening of the inferior cable vein. I'm now opening the left atrium to show you how this inferior cable vein is riding the posterior margin of the oval fossa. There you see that posterior margin of the oval fossa. Now when we look at this from the right atrium, and when we open up the right atrium, it's very easy, as I showed you in the normal heart, to look in there and to imagine that this is the margin of the oval fossa. But that would be a terrible mistake to make, because you see that behind that margin is the mouth of the inferior cable vein. So, in fact, the inferior cable vein is riding this anterior margin of the oval fossa. The oval fossa, which is pro-patent, as you see it there, is forming the medial wall of this crevice within the right atrium, and it is crucial for the surgeon going into a heart such as this not to mistake this, which is the valve of the inferior cable vein, as the margin of the oval fossa. We're now going to move to discuss more complex forms of interatrial communications. So I'd like to start by orientating you to the heart I'm going to show you, which is somewhat more complicated to the ones we were looking at previously. We're looking here at the diaphragmatic surface of this heart, the opening of the inferior cable vein, the crux of the heart, the posterior interventricular groove. And you will note that in this heart there is a persistent left superior cable vein which comes down, opening between the left atrial appendage, the left pulmonary veins, to enter the posterior left atrioventricular groove and to open into the right atrium through the mouth of the coronary sinus. And there very nicely you see that large mouth of the coronary sinus that I'm entering with the tip of my probe. Now the rest of the septal morphology of this particular heart is grossly distorted. There from above you see the vestibule tricuspid valve, and in this position we see the mouth of the superior cable vein. Superior cable vein is entering into the atrium in relationship to the terminal crest, but here the interatrial groove is directly continuous with the roof of the left atrium. In fact, in this heart, the oval fossa is completely lacking. This heart shows a variation on what we call a sinus venosus defect. This is not a typical sinus venosus defect, because in this heart the oval fossa is completely lacking. It has never been formed. Instead, we have here the inferior rim of the oval fossa, and you see that the superior cable vein, or rather the mouth of the superior cable vein, is riding that rim of the atrial septum so that it enters directly into left and right atrial chambers. And it is this riding of the atrial septum by the mouth of the superior cable vein that is the essence of the so-called superior sinus venosus defect. Now, as a consequence of that, the right pulmonary veins enter into this junction of the superior cable vein with the roof of the left atrium. In the more typical sinus venosus defect, where the oval fossa is preserved, the pulmonary veins more frequently drain closer to the superior cable vein, and that is another cardinal feature of the sinus venosus defect. So this particular superior sinus venosus defect is complicated by the absence of the oval fossa, but still we see its cardinal feature. Now the surgeon repairing this defect must repair it in such a way that the pulmonary veins continue to drain to the left atrium. The overriding superior cable vein is reattached within the right atrium. Sometimes to do that, it is necessary for the surgeon to place baffles across the cavoatrial junction. If the surgeon does that, he must be careful not to cut in the position where this appendage has been opened, because that cut passes directly across the site of the sinus node, which, as Dr. Ho showed you, is at the junction between the wall of the superior cable vein and the terminal crest of the right atrial appendage. The surgeon must also be careful not to damage the arterial supply to the sinus node, and the artery to the node can come anteriorly across the cavoatrial junction, or posteriorly behind the cavoatrial junction, or in some circumstances form a circle. So for the surgeon operating on the sinus venosus defect, the major danger area is the lateral margin of the terminal groove here, containing the sinus node. When repairing the defect, he must be careful to reattach pulmonary veins to left atrium, superior cable vein to right atrium. The cardinal feature is the overriding of the septal crest by the superior cable vein, and exactly the same feature in the mouth of the inferior cable vein would produce the inferior sinus venosus defect. So, to conclude this consideration of interatrial deficiencies, we're going to look at those interatrial communications which use the mouth of the coronary sinus as the link between the atrial chambers. And I'm going to show you, first of all, a partial form of this malformation. I've opened the heart that you're looking at through the right atrial chamber, and you'll see that this is the typical form of tricuspid atresia. The floor of the right atrium is entirely muscular, so there is no communication from the atrial chamber directly into the ventricular mass. As we saw last week, this entity, classical tricuspid atresia, is due to complete absence of the right atrioventricular connection, and in this setting, the right ventricle is incomplete and rudimentary. This particular heart had undergone surgical correction using the Fontan procedure, and part of that procedure is to close the defect which almost always exists within the oval fossa, so that in this heart a patch has been placed to block the oval fossa. In this heart, however, you also notice that when we look at the posterior aspect of the atrioventricular groove, and here is the crux of the heart with the posterior interventricular artery, here's the posterior extent of the rudimentary right ventricle, here the left atrium with the pulmonary veins entering it, the typical morphologically left atrial appendage. In the left atrioventricular groove there is rather a prominent coronary sinus. And in fact this degree of prominence of the coronary sinus is what we might expect when there's persistence of the left superior cable vein. And just a few moments ago we were looking at a heart with persistence of the left superior cable vein, and we showed how that came down between the left atrial appendage, the left pulmonary veins. In this particular heart there is not a persistent left superior cable vein, but what there is a very interesting malformation which is particularly important after the completion of the Fontan procedure. Because there you see that on the anterior wall of the coronary sinus are small fenestrations. Where do those fenestrations go to? When we open the left atrium, we see that they are connections between the coronary sinus and the left atrium. So now, because of this partial unroofing of the coronary sinus, there will be a persistent shunt between the right atrium and the left atrium at the completion of the Fontan procedure through the fenestrations in the wall of the coronary sinus. So, the presence of these fenestrations between the coronary sinus and the left atrium mean that the mouth of the coronary sinus is functioning as an interatrial communication, even though it is not part of the atrial septum. And indeed, you can see the consequence of that to the surgery in this particular case. The surgeon is under the impression that he has totally closed the atrial septum, which indeed he has, but the presence of these fenestrations give the potential for a continuing left to right shunt after the completion of the Fontan procedure. The final heart we're going to look at in this afternoon's presentation continues the progression into anomalies of the coronary sinus, which result in the mouth of the coronary sinus functioning as an interatrial communication. In the previous heart I showed you, there was a small fenestration in the party wall between the body of the coronary sinus and the left atrium. This heart is more interesting and shows a more extreme form of what we can call unroofing of the coronary sinus. You see that we are looking in from the right atrial aspect, the appendage of the right atrium with its typical morphology, pectinate muscles. If we look in at the septal surface of the right atrium, you see that the oval fossa is present in this position and is in fact intact. Behind and inferior to the oval fossa, however, is a large interatrial communication, and that is precisely at the anticipated site of the coronary sinus. Indeed, it is the mouth of the coronary sinus. If we look at the left side of this heart, we see that now, unequivocally, this mouth of the coronary sinus is functioning as an interatrial communication. And in this heart, because the wall of the coronary sinus between the left atrioventricular junction and the right atrium is missing, the coronary sinus is now incorporated as part of the interatrial septum. So this is a fundamental difference relative to the normal arrangement. We can see that this is not the oval fossa, because there is the opening of the oval fossa on the left atrial aspect of the septum. So here we have the mouth of the coronary sinus incorporated into the atrial septum and now functioning as an interatrial communication. Most usually, when we see this large opening of the coronary sinus functioning as an interatrial communication, there is evidence of a left superior cable vein draining to the atrial roof, and sometimes there is even evidence of the track which initially connected the persistent left superior cable vein to the mouth of the coronary sinus. In this particular heart, however, there is no superior cable vein connecting to the atrial roof, and so the mouth of the coronary sinus is functioning in isolation as an atrial septal defect. And if we look at the right side, you can see that the difficulty that might ensue in diagnosing this as a coronary sinus defect. The key to diagnosis is to observe that the oval fossa is present, but is pro-patent, so that deficiency should be seen echocardiographically. And then there is another defect postero-inferiorly related to the mouth of the inferior cable vein at the site of the anticipated mouth of the coronary sinus interatrial communication. In this afternoon session, therefore, we've looked at the specific morphology of one given lesion, holes between the atrial chambers. I've shown you how the true atrial septal defect is found only within the oval fossa, but I've also shown you how other more complex malformations can result in interatrial communications, but not through the oval fossa. So in this respect, we've seen the superior sinus venosus defect, and we've seen the situation in which interatrial shunting occurs through the mouth of the coronary sinus. I should emphasize to you that we have not looked at the one other important lesion which oftentimes is described as an atrial septal defect, namely the ostium primum defect. We have left that lesion out on purpose because, as we will see in one of our subsequent presentations, that ostium primum defect is in reality a deficiency of atrioventricular septation, or, as we prefer to call it, an atrioventricular septal defect. That lesion has its own particular anatomy, and to understand that anatomy, we must compare the abnormal morphology produced by the atrioventricular septal defect with the situation that pertains in the normal heart. But as I say, that is a topic for one of our future presentations. Today, we were concerned with true atrial septal defects, and those defects which simulate atrial septal defects, namely sinus venosus defect and the communication through the mouth of the coronary sinus.
Today's session is on anomalous systemic venous and anomalous pulmonary venous connections. We begin by looking at a diagram of the normal systemic and pulmonary venous connections. This is very much a stylized diagram showing the superior cable vein, inferior cable vein, and coronary sinus entering the right atrium. The oval fossa is depicted in purple here, and on the left side we have the pulmonary veins entering the left atrium. In dotted line we have the site of the persistent left superior cable vein, but this is usually obliterated or ligamentous, leaving just the coronary sinus to open into the right atrium. Before considering anomalous venous connections, we have to define what is anomalous venous connection. It is a vein that drains into its inappropriate atrial chamber. Furthermore, we have to distinguish between anomalous connection and anomalous venous drainage. On very rare occasions, the vein may be normally connected but drain anomalously, and this we will look at later in the session. The most common form of anomalous systemic venous connection is that of persistence of the left superior cable vein, as shown on this diagram here. It occurs in about 0.3% of general autopsies, but when talking about autopsies concerning congenital heart malformations, the incidence rises to between 2 and just under 5%. It consists of a venous channel which duplicates the right superior cable vein, but it comes in here and is continuous into the coronary sinus to empty into the right atrium. As you have heard last week, the persistence of the left superior cable vein in the normal situation, that is in the situation with usual atrial arrangement, can sometimes occur in association with fenestrations or incompleteness of the roof of the coronary sinus, giving direct communication of the superior cable vein, the persistent left superior cable vein, into the left atrial chamber. This morning we're going to look at basically hearts with usual atrial arrangement in the context of anomalous systemic and pulmonary venous connections. We're going to leave the anomalies of venous connections in hearts with atrial isomerism to a later session, because they can be quite different from what we see in those with usual arrangement. Well, here we have a specimen with persistence of the left superior cable vein in the presence of a right superior cable vein. In about 3/5 of hearts with this sort of situation, there is a brachiocephalic vein connecting the right superior cable vein across the front to the left superior cable vein. In the remainder, this connecting vein is absent. So when you find an absence of the brachiocephalic vein, that raises an index of suspicion that you have a persistent left superior cable vein. Let's look at the course of the left superior cable vein, and to do this I turn the heart round to its left side, and we find that here it is between the tips of my forceps. We follow it downwards, it goes along there and comes in towards the left atrial chamber between the left atrial appendage here and the left pulmonary veins here. I've chopped off the lungs in this specimen to make it easier to see the position of the left pulmonary veins. This little vessel here is the hemiazygous vein entering behind the left superior cable vein. So note the course of the superior cable vein. It passes in front of the left pulmonary artery and also the left main bronchus deep down here. Following the course of the persistent left superior cable vein further down, we can trace it to the back of the heart in the left atrioventricular groove, and we see a bulge in this area of the left atrium, and a cut has been made into the left atrium in this heart to show the very wide opening of the persistent left superior cable vein. We follow this cut across to the other side, and we can match the hole here in the left atrioventricular junction, a very wide hole, the left atrial wall up here, left ventricular myocardium down here. We can just about see part of the leaflet of the mitral valve. If I put my forceps in this hole and we continue to turn the heart around from the diaphragmatic surface, we now look at the heart from its right side. We can see the tips of the forceps opening through. We're looking into the right atrial chamber. We can recognize up here the terminal crest with the pectinate muscles, and we see the forceps in the mouth of a widely open coronary sinus. Up here we see a patch which has been used to close an oval fossa defect. So when we see an enlarged opening of the coronary sinus, we take the forceps away. Here we are. A very large round hole. We should suspect that there is either anomalous systemic or anomalous pulmonary venous connection. The latter we will deal with later on in this hour. If we then turn and look at another heart with a similar malformation, we see here around the back, I have packed it up with tissue paper to show quite nicely that looking at this heart from the back, we see a very dilated entrance to the coronary sinus from the persistent left superior caval vein, remembering that we are viewing the heart from behind. And up here we have the persistent right superior caval vein. Again, this heart has been cut into the left atrium. If we open up the left atrium, or try to open up into the left atrium, we find that in making a cut in the back of the heart, we actually open into this very wide coronary sinus orifice, and here is its communication with the right atrium. The left atrium is actually behind this party wall. There's the roof of the coronary sinus. You see a little bit of white substance here. This is actually super glue, which I have attempted to repair the heart with. And I'm just trying to make a hole in the original cut to show that this is how you can get into the left atrial chamber. So by making an opening into the roof of the coronary sinus, you actually get back into the left atrium. Here we show the forceps passing through the left atrium and through the orifice of the mitral valve. If we look closely up here, we might be able to see the valve of the great cardiac vein, the valve of Wissens, just between the tips of my forceps here, at the junction between the left superior caval vein and the coronary sinus here. Another systemic venous anomaly is that of interruption of the infrahepatic segment of the inferior caval vein. These hearts are usually associated with isomeric arrangement of the left atrial appendages. For instance, in this heart, we see on the left side a morphologic left atrial appendage, and similarly on the right side another morphologic left atrial appendage here, very long and slender looking. If we turn the heart back to the left side, we see the superior caval vein here entering the roof of the left-sided atrium, and behind it is a large and dilated hemiazygous vein. This we describe in general terms as azygous continuation of the inferior cable vein. But as I've said, this occurs much more frequently in hearts with left atrial isomerism. The inferior cable vein has been described in a few case reports as draining directly into the left atrium. We do not have such a specimen in our collection, but sometimes anomalous insertion of the inferior cable vein is associated with an interatrial communication, for instance, in this heart with an inferior sinus venosus defect. I have my forceps right through there. It's just on the underside of the atrial septum here. We see the floor of the atrial septum in this position. I folded back the free wall of the right atrium with the terminal crest along here. If we look closely down in this position, we will see that because of the insertion of the inferior cable vein as it enters the back of the atrium, its flow is divided by the lower edge of the atrial septum or the upper edge of the inferior sinus venosus defect, dividing the stream of the inferior cable vein into the right atrium one side and into the left atrium on the other side. If I pull out the heart in this position, we will see that there is, in this case, a very prominent eustachian valve. Surgical correction was attempted in this patient by placing a patch across the inferior sinus venosus defect. But as you can see, this heart has a very prominent eustachian valve, and it is very easy to mistake this eustachian valve for the inferior margin of the inferior sinus venosus defect, and then place a patch across in this position, diverting inferior cable flow into the left atrium. So an anomalous connection of the inferior cable vein is frequently associated with an inferior sinus venosus defect. Another situation in which the inferior cable vein can be normally connected, but the flow can make it appear as if there is anomalous connection of the inferior cable vein. In this situation, it's a very small heart, but I have my forceps into the orifice of the inferior cable vein, and you can see that it's passing into the right atrium, but between a very membranous structure here, which is the persistence of a very large eustachian valve, which in fetal life directs flow through the oval fossa into the left atrium. So if this venous valve persists in its very extensive extent, it can create a situation in which inferior cable flow is shunted directly to the left atrium. Moving on to anomalous pulmonary venous connections, when we look at anomalous pulmonary venous connections, there are a few questions we should ask. Firstly, how much of the lungs are anomalously connected? Secondly, where is the site of anomalous connection? Thirdly, are there any regions of obstruction or stenosis in the anomalous vein? So if we